And I'm going to turn this over to Hannah. She's going to talk about the first couple set of research studies to come out.
Thank you, Lauren. So as I mentioned earlier, we were discussing about how individuals with disabilities face a greater risk of being diagnosed with COVID-19. And there's a lot of research that is coming out that supports that statement. So this first bullet here, a study by Gleason and colleagues, they analyzed patient records from over 500 healthcare organizations to look for risk factors for contracting and dying from COVID-19. So of the over 64 million patient records that they were able to obtain and analyze, 128,074 were patients with intellectual disabilities. So they analyzed these records along with comorbidities and demographic factors such as age, gender, race and ethnicity, and socioeconomic status to estimate the odds of being diagnosed and dying from COVID for this population. So they found that having an intellectual disability was the strongest independent risk factor for diagnosis of COVID and the strongest after age for mortality. So to summarize, individuals with an intellectual disability were more likely to receive a COVID diagnosis, regardless of age, gender, race, ethnicity, social class, and comorbidities than their peers without disabilities. And having an intellectual disability was the strongest independent risk factor after age for mortality from COVID-19. The second study listed is one focused on individuals with intellectual and developmental disabilities living in New York City and receiving residential services from a nonprofit organization. These residential services included 3 distinct types of settings. So one was assistance, where they would provide assistance with activities of independent daily living activities, and those averaged about 8 to 10 hours per week. The second setting is where staff provided 24/7 on-site support, but only intermittent medical care. So they would help very hands-on with independent daily living, but health-wise overall, the individuals were, fairly healthy. And the third provided 24/7 on-site staff support for complex medical needs. So you had a wide range of residential services, but what they found among 543 individuals with intellectual and developmental disabilities in the study, the median age of individuals was 57 years old, so it was an older, slightly older population. 40% were female and 50.5% were non-white, so Black, Hispanic, Asian American, etc. So during the course of this study, 91 individuals, that was about 17%, were diagnosed with COVID-19, and 35 individuals, about 6%, were diagnosed, who were diagnosed with COVID, died from it. So they found that, similar to the general population, increased age, number of residents, and having a chronic kidney disease was associated with diagnosis of COVID. So they faced a higher odds of contracting COVID in the first place. Having Down syndrome was also a risk factor of contracting COVID. And a similar, again, to the general population, those with heart disease were more likely to die from COVID-19. Next slide, please. So this next study we found was a scoping review of 2020 articles. As Lauren was saying, they've been kind of slowly coming out, and this actually, the inclusion criteria was 2020 articles that were focused on COVID-19 and individuals with intellectual and developmental disabilities. So they found a total of 16 studies that met this inclusion criteria. And it was clear from all of the articles that individuals with intellectual and developmental disabilities and their caregivers are vulnerable to not only diagnosis of COVID and serious clinical outcomes, but also a lot of, what Lauren was talking about, disruption to services and routines. So their challenges were more than just related to contracting the virus. So they're at an increased risk of getting this virus. So you've got that stress, but also a lot of, their lifestyle was upended as well. Next, please. So this study by Redquest and colleagues looked at how the pandemic affected adult siblings of adults with intellectual and developmental disabilities. So this was actually based in Canada, and they surveyed 91 adult siblings to see, what impact, if any, COVID had on the relationship with their sibling, how they felt towards their sibling, their kind of stress level related to everything. And they found that most were supporting their brother and sister in some way. They might not have been their direct caregiver, but they were providing support. And nearly all siblings were concerned about their sibling with an intellectual or developmental disability. They're especially concerned about their health. So again, this contracting the virus, but they were also concerned, for their mental health and disruption of the routines and how, long-term, but also short-term, that was going to affect their sibling. Next, please. And this one by Jest and colleagues, they surveyed over 800 caregivers of children and adults with intellectual and developmental disabilities. The majority of respondents were in the United States, and most had children under the age of 22 with a disability. There were a handful, about 160, who had adult children with a disability. But most caregivers reported that their child lost access to at least one therapy or education service, while some even lost access to a healthcare provider during this time. Over half reported that they used teleeducation in place of, face-to-face, so that their children could continue to receive some of these services. And most said that teleservices were helpful when they were available, but they didn't replace the one-on-one access that was needed. So similar to what Lauren was talking about, a lot of these services and supports do not transfer over to teleservices, and it created a lot of conflict and stress for family members, as well as the individual with an intellectual or developmental disability. That's it for me.
And I just want to piggyback off of Hannah's point there that, as we continue to describe some of the findings from the research and also some of the impacts we saw early on, that these services didn't transfer well or generalize well, I just want to highlight the point that doesn't mean that they can't transfer well. It just means that they didn't in the ways that we tried to transfer them. And so as we move forward, I think the bigger question is, how do we make them more flexible so that they will transfer better? Because it's very likely that some of these will be necessary in other contexts in the future. So we just didn't necessarily do it the best way. And that's something that we can all learn from, I think, as a field. So thank you, Hannah. I'm going to just go over about 3 more quick studies that also came out. And you can see here, of course, that these are very new studies, all really late 2020 or 2021. And so we do expect that quite a bit of researchers will be continuing to wrap up some of their findings and reports. So it's exciting to know that we'll have a lot more empirical direction coming at us in the future. This Shaw et al. Article is looking at employment. So the impact of COVID-19 on employment, not only employment status, but also number of hours worked and wages for individuals that had intellectual and developmental disabilities. And this one was conducted in the United States. This organization is an employment organization. And so the way the study was conducted, the researchers looked at records from 2020, which was after the pandemic hit, and then compared that to a similar group. So in other words, matched for age and other characteristics before the pandemic. And I don't want to confuse anyone, but the fourth bullet point, 133 out of the 156 were the same individuals. So really just what that means is that, to clarify, the 156 individuals were not 156 that were employed before compared to a different set that were employed after. It's data aggregated from before and then another sample after, and then 133 of those individuals overlapped between the two data points. So I just want to put that point out there for anybody who's sort of parsing their way through the method section of this research study. But the takeaway message here, and I think what's important, is that 156 individuals, and this all came from one state, they weren't able to work from home. So the vast majority of them were not able to simply transfer from the position they were at pre-pandemic to for however they might, whether that's working from home or simply the institution or business shut down. The takeaway message is that the vast majority were not able to simply transfer to homework and continue life as normal the way other individuals were. And in that, they were either furloughed or were laid off. So they were substantially impacted employment-wise by the pandemic. Not surprisingly, then, the number of hours worked substantially decreased once work resumed compared to before shutdowns. So we did see that once individuals were returning to employment, they just weren't working as many hours as before. And there could be a lot of reasons for that. I don't know from the research study in detail. It could be that the business itself wasn't open for as many hours as it was prior. We definitely saw that with a lot of businesses. Or because of the economic impact, businesses really had to cut hours for employees to try and recoup some of their financial losses. We did, however, see that wages were not affected. So there were not pay cuts reported by the individuals in the study from pre to post pandemic. So it was really more that the number of hours they were working were affected rather than their pay itself being decreased. And then food services, retail, and entertainment were more affected than other industries by the individuals reported in this study. And also, I mentioned earlier on the research slide, this was really the only very specific detail I could get into demographic information. But surprisingly, the Black, Indigenous, and people of color represented in the sample, they actually worked more hours than their white peers. So that's atypical to what we find in other research studies. But we did find here that, the impact actually favored those individuals rather than what we typically see as them being hit more hard by working less hours or being less employed. Okay, two more studies to go over quickly. Rose et al. 2020, this is the United Kingdom study. And I included this study because I've talked a little bit here now about the different life domains. And I just mentioned employment, so I wanted to get into education and independent living. So this study was a very simple study. It was just really looking at, again, what the actual impact of COVID-19 was. And it's just really reiterating some of those earlier notions that we found. So when they actually talked to individuals and their family with DD and their families, they found that a child who is assessed is needing very direct one-to-one ratio support in a school context, were typically sent home to the family with no support. So that was one of the most common educational issues families described experiencing. So basically that it was recognized by the school that the child needed very intensive support, but when they switched contexts, that acknowledged need for that level of intensive supports did not transfer with them. And then in terms of residential, the issues that were reported by families in the UK, many adults that had developmental disabilities who were living in residential care facilities couldn't stay within that residential care facility. And they didn't specifically state necessarily why. It could have been the family's decision to take them out rather than any other reason. But in any event, this left many families having to experience for the first time how to provide support for their family member at home rather than in the residential care facility. And these, of course, are families who at one point had determined that that individual family member with DD needed that level of care. And so when they transitioned their family member, they didn't really know how to access that support, have experience doing it, or know any of the legal or financial pieces they might need in order to do that adequately. So in addition to then families having to provide care for the relative and then taking on that stress, the last issue that was most commonly reported by families was something we've mentioned a lot in this presentation. It's just the restricted access. So families that did have to make the decision about whether or not to leave a family member in a residential care facility, then oftentimes had very limited access to them and less knowledge about how they might be doing physically or mentally as a result of that. Then the last study I wanted to go over is just a survey. It's a large survey, so it was 582 people who had intellectual and developmental disabilities in Spain. And again, just to note the different types of impact on different life domains. The first one's health. And I thought this was a really positive statistic, and that's in contrast to a lot of what we're talking about today. So people who had an IDD reported that they were fairly satisfied with the information that they had been given about the pandemic, and that the main avenue in which they received information about the pandemic was actually through disability organizations. And they felt that information was really useful and easy to understand. And so I think that's a good takeaway lesson, particularly later in this presentation when we show you some of the types of documents that mirror this, this perspective. But the examples that they quoted were different informative seminars on state of the health emergency, so just knowing what the current state was, different types of information guidelines, and then adapted documents that were in plain language formats. So again, just to summarize, the individuals with ID that were surveyed found that this type of information was really helpful and useful to them. So it's certainly something you would want to emulate in the future when providing information or knowledge dissemination. So then education, for this particular sample, this was parents who reported on their 3 to 21-year-olds and said that students were most likely to not receive the necessary support from their school or other services. So to kind of put that into context, of all of the age groups that were represented in this survey, which includes adults as well, respondents felt that students aged 3 to 21 were the least likely to get the supports they needed and in the educational context. And then lastly, employment. So the majority of workers were unable to continue working, and this is similar to the Shaw et al. Article that I just mentioned. But I do want to cite that they didn't say that lack of support for those that were working was an issue. So in other words, if an individual was still working during the pandemic, it didn't come across in the survey as the supports they were receiving were lacking. So I think that that's an important point and kind of guides us to know that there is an effective way to do that, to provide supports in employment context. Okay, I'm going to talk about support strategies now. Getting ahead of time. And as I go through these different support strategies, they'll target healthcare, employment, and education again. And I have a list, and I just want to point out that while this is very wordy, all three lists are like this. They come directly from a table in the article that Hannah mentioned at the very beginning. So in case you forgot a bit about that, Hannah and I and a few other colleagues published an article early on about the impact of COVID and some of the support strategies that could be used for different stakeholders in order to more collaboratively work together to reduce the impact in those different life domains. So the bulleted list that you'll see comes straight from that article. And as Hannah mentioned, the article is free to access. So you can always go and grab that if you want a tool at some point in the future. And they're broken up again into targeted providers. So the first one's going to target healthcare providers. The second list is going to target employers or businesses. And the last one is going to target educators. And so I want you to think about these support strategies as if one of these individuals, a healthcare worker or an employer or an educator, came to you as a different stakeholder, as a vocational rehabilitation specialist, as an individual with a developmental disability, as a parent or family member of somebody with a developmental disability. This is sort of a list of things that you could direct them to try and think about ways to provide effective supports and services to reduce the impact of something like a pandemic. And if you are the people that fall into the category that's being targeted, kind of a nice list for you to sort of think about how you could collaboratively work with other stakeholders. So I'll just go through the list. And again, I want you to kind of keep that in mind. This is more of how to create a teamwork approach to helping during a crisis. So for healthcare providers, first and foremost, it's sad that we even have to put this in here, but a friendly reminder that treatment is not to be denied based upon the presence of a disability. First of all, legally speaking, that's not kosher, but also we saw at the beginning of the pandemic a lot of difficult decisions that were being thrown around by healthcare providers in the event that they would have to prioritize where to provide treatment. And the concern early on came to be that individuals that had different disabilities would be disproportionately affected in a negative way. And so we want to just, again, at the focal point, remind anyone that that is not an option. And then as we move through these other bullet points, they really look at some more sort of actionable strategies. So also reminding healthcare professionals not to underestimate or overestimate an individual who has a disability, DD or IDD, to understand medical conversations. I think this is an important point because we do tend to target making sure that we don't overestimate. So for example, we talk a lot about providing an explanation that might be individualized to a person that has an intellectual and developmental disability. But we also sometimes see that healthcare provider, because a certain individual presents as very compliant or maybe has body language that insinuates understanding, that they often assume that they do understand rather than maybe checking, like asking them, could you tell me what I think you mean by that, or asking other pro questions, because this is certainly not a time to assume that an individual understands different, for example, personal protective equipment procedures, because the risks are really high if they don't. The third bullet point is asking for permission from the individual with DD when discussing about them with others. So we want to go back to making sure that healthcare providers understand that even though there might be a liaison, that we want the individual with a developmental disability to have consent. We want to respect their dignity and make sure that they're comfortable and choosing who it is they would like to have access to information about them. We also want to confirm if the individual has a trusted caregiver or an advocate or any sort of liaison or anybody that might act even as a translator to include in medical conversations. So if there is a target person, we want to be sure that healthcare providers know to think or to ask about who could be included and be flexible in ways that they could include them. Certainly, hospitals have protocols, and a lot of those changed during the pandemic to make sure that they limited the amount of people that were present in healthcare rooms, but there are alternate ways to sort of involve a third party. And so we want healthcare providers to be thinking creatively about ways to do that that could be effective. Also, making sure that healthcare providers don't assume that individuals with developmental disabilities already know changes in routines or procedures as a result of the pandemic. So beginning routine visits with a sort of a summary or list of what the new protocols are to make sure that they're on the same page. Making sure healthcare providers use plain language or non-medical terms. Providing accommodations that enable continued care. So again, such as a trusted caregiver. And really what we're getting at with that bullet point is that, there are, again, changes to protocol for healthcare facilities during something like a pandemic, but there are also times when necessary allowances might need to be made, and that often applies to individuals that have developmental disabilities. And so we want to be sure we're asking them to take those allowances when it benefits the individuals we work with. So I should have numbered these. It might be easier for you, but I, in hindsight, did not. But I'm about halfway down the page here of the bulleted list. And so the one that says ask caregivers about picture cards, icons, dry erase boards, or other assistive technologies that might need to bring with them to a medical visit for communication. This is a really important one. So we want healthcare providers to be aware that individuals with DD often communicate differently, and if they don't have the tools they need, such as picture cards or dry erase boards or any sort of speech language generation device, they won't be able to communicate effectively and they won't get equitable healthcare services. And many healthcare providers don't know that that is something an individual might need. And so we can also encourage them to keep things like that around in their offices. So just having a dry erase board or maybe some picture icons that could help them communicate in a pinch would be really helpful. So I'll kind of breeze through the last few of these, encouraging health literacy by making messages distributed to the public accessible. We definitely need to be vigilant of having multiple formats for individuals to access information rather than one. And a lot of disability organizations and other state efforts have focused in on that. So we'll show you some examples in just a bit. And then also I just want to kind of mention before I move on to the next slide, the best way to make sure that we are targeting effective strategies for healthcare providers is making sure in that last bullet to get individuals that have DD on ethics teams and discussion panels and getting their voice heard about what they think would be most helpful or what they have found to be helpful, and also what they've found hasn't been helpful. So we can really move forward in a way that reflects their experiences and better it in the future. Okay, I'm going to talk a bit about support strategies for employers. So again, this is targeting employers in the sense that if you were to work with an individual or have a son or daughter who had DD and was employed, how might you help a business owner or supervisor accommodate some of the pandemic challenges? And so one of the first things you can do is sort of be that liaison to them and be generally aware of the type of support that individual needs. to perform different tasks, and then be the person that helps the employer or business understand what those different supports are. Oftentimes they're not aware, it's not their job to be aware. Um, so being able to sort of quickly step in and say, this is the kind of support the individual needs is immediately helpful. So telling employers on that second bullet that having kind of an open dialogue with an employment specialist or any sort of employment service provider about different ways that changes in protocol or procedures can be explained to the individual with DD is really essential. So maybe helping them understand how to create a schedule or use different technology, or maybe put different visual cues. So for example, we all saw, again, the arrows in the grocery store showing you which direction to go. So an individual with new changes in, let's say, protocol to having to wear a mask or a face shield, having maybe visual prompts in the back of the store or wherever they might work as a reminder before, like after they clock in, just kind of having an idea of how to support them. Proactively asking what remote employees, so those that worked from home, might need. So for example, an email might go out to everyone working remotely that, again, they need to now log their work tasks using a certain document. Just letting employers know that, an email might not be sufficient for that. You might actually need a checklist or maybe a visual schedule to help them understand how to do that. And then kind of encouraging employers to be patient about extra training that might be required for individuals that don't necessarily respond well to abrupt changes in protocol. Offering simplified versions of pandemic instructions, asking what accommodations an employee with DD might need to minimize exposure. And then just kind of having an open door policy, which allows an employee with DD to feel comfortable asking questions. So what we've found as sort of vocational support services is that we build relationships with businesses, and businesses that have an open relationship with our staff feel more comfortable asking us questions about how to support individuals with DD that we work with. And it's convenient for them to contact us because they know us well, they feel comfortable contacting us. And when something like a pandemic arises, because the relationship is already so strong with our agency and the employer, that open communication really doesn't waver. And so I think the takeaway message there is that while it's important to sort of offer all of this support to employers during a crisis, it really goes back to the fact that if you already have an existing relationship with a business, the stronger that is, the better off you'll be. So really, these are things that are kind of helpful in general, and we just want to make sure that we reinforce them when a pandemic happens. And again, particularly with employers, employers are not trained to understand the different types of supports and services an individual with DD might need. They really are, that's not their specialty. They don't have any sort of like backdrop training for that. So the emphasis is really on us as support providers or family members to be that bridge for them, much more so than is true for educators or healthcare professionals. And I do want to just say, although I've gone past the healthcare providers and onto employers, that oftentimes healthcare providers, there's an assumption that they have similar training too, and that's not necessarily the case. In fact, there is an effort now at quite a few different medical schools. I think it's out of Ohio. I won't say the university because I'll probably get it wrong, but I do know that it's in Ohio. There's an initiative right now for medical residents to get better training on, for example, autism spectrum disorder supports and what that might require. And this whole initiative is really looking at training them before they go out as licensed practitioners to better understand how to work with an individual who would come in seeking medical services. And that's anywhere from understanding some of their communication differences, maybe some of their behavioral needs, how to anticipate some stressors or triggers that might impact their experience when they're receiving healthcare. So I just mentioned that because I want to highlight that it's often, again, perceived that healthcare individuals are already up to speed about what to do, but we do know that that's not necessarily the case. And it makes it even more important for us to kind of be that bridge and that liaison